Okay, so I think we're going to try to stay on time. So let's start the second session. This one is going to focus on cancer screening and diagnosis. So focus on the prevention perspective of cancer. And our first speaker is Dr. Otis Brawley. He's the medical director of American Cancer Society and has recently become a journalist, in case you haven't read his book. Thank you, Otis.
Thank you very much. It's a true pleasure to be here, and thank you to the organizers for this. I'm going to, over the next 20 minutes or so, talk about screening, talk about health disparities, and make a few comments about the healthcare system in general. As has already been noted, I do have a conflict of interest in that I published a book earlier this year that's very much about this subject. I am going to basically make the argument over the next 20 minutes that part of the problem is that we in medicine have overpromised our magic. Part of the problem is that we in the United States have decided to accept a subtle form of corruption in which the greedy feed the gluttonous, the greedy being those in healthcare who want to make a dime, the gluttonous being people in the United States who've decided that because of all the promises, there's no reason for anybody ever to die. The fault you see in the healthcare system is it lies with the doctors, it lies with the hospitals, the blame lies with the government, the blame lies with the insurers, the lawyers, the patients, patient advocacy groups. There is no one who is not to blame for the problem in American healthcare. One of the great problems is that we treat. We use this treatment paradigm. Even when we prevent disease, when we prevent heart disease, we treat hypertension. When we prevent heart disease, we treat cholesterol. We do not have a culture in American medicine that actually favors prevention. Now, as those of you know, I've been involved with a number of prostate cancer studies. I want to take one quick survey. I do this in all my talks these days. If you do what I think everybody ought to do every once in a while, pretend that you're a 55-year-old guy and that a pill exists. And if you take this pill, it will definitely double your risk of being diagnosed and therefore treated for prostate cancer. That doubling is an absolute increase from 10% to 20%. And by the way, doctors use absolutes and relatives to their advantage, so I'm giving you both of them. If you take this pill, while it doubles your risk of being diagnosed and treated from an absolute of 10% lifetime to 20% lifetime, there is some data to suggest that it may lower your risk of prostate cancer death by 20%. That is from an absolute risk of 3% to an absolute risk of 2.4%. How many people would take that pill here? Couple? Okay. Now, I was told to talk about screening and disparities, so you're going to get that in about 6 slides. These are just the percentages of people. Mammography, there's little controversy there, just a little bit, but there's about 60% of women getting mammography. I just want you to note that the uninsured tend not to get it, the insured tend to get it. For education, the more educated people are, the more likely you are to get mammography within the last 2 years. For Pap tests, perhaps the most the test that has the least controversy, you can see it's 70 to 80% of people getting it, with the uninsured not getting it much more so than the insured, which is especially a problem because there's a study to show that of the 4,000 women who died of cervical cancer in 2006, half had never had a Pap smear, and the half that had had a Pap smear, 90% had not had one in 10 years prior to diagnosis. So you see, there's a huge disparity. There's the people who get Pap smears and don't die, and the people in the U.S. who don't get Pap smears and do die. Again, there is a a gradient here with more educated women more likely to have gotten pap smears. Fecal occult blood testing and endoscopy, you can see some racial differences with whites out in front. Health insurance, again, being a huge gradient. And then, of course, with education, increased education, more likely to have gotten some form of colon cancer screening. Now, from 1900 to 1991, there was an increase in mortality for cancer overall, and you can see the significant increase. 1991 was the pinnacle year, and from 1991 to 2010, there's now been a 20% decrease in overall mortality from cancer in the United States. Now, why the decline? Actually, prevention, smoking cessation especially, is the leading reason why there's a decline in people dying from cancer. Early detection, that is women saying, "What is this in my breast?" while in the shower. People saying, "Why is there blood in my toilet bowl?" Presentation with early disease because of realization of symptoms. Improvements in treatment. And the last reason why there's been a decline, and fourth overall, is screening, cancer screening. Most people actually think screening is far more important than it actually is. I got in trouble for telling the New York Times that once. Screening in breast cancer, for example, is responsible for about 30 to 40% of the 33% decline in mortality over the last 20 years. We forget treatment is incredibly important. These are the racial mortality statistics as published by the National Cancer Institute. You can see blacks and whites have a disparity compared to the other racial ethnic groups. These are racial ethnic groups that are defined by the Office of Management and Budget in the White House. So they're socio-political categorizations. They're not biological categorizations. Sociopolitical are actually important as they actually talk about what we eat, what our culture is like, how we interact with the environment, and they do correlate with socioeconomics. When I say correlate with socioeconomics, this is something that our group at the ACS did. We took people, black Americans aged 25 to 64, and said, how many cancer deaths would have occurred if we gave all black Americans the death rate of college-educated black Americans. And you can see that there would have been roughly 10,000 less deaths. 41% of the total deaths in this age group would have been prevented by correcting for socioeconomics. If we gave them the death rate of whites in the United States, only about 4,000 or 20% of the deaths would have been prevented. So socioeconomics is far more important than race. Now, it's a fact that health care is being rationed and that a substantial portion of people do not get adequate health care. There's numerous studies that show that up to 30% of women with breast cancer, be they black, white, or other, are getting less than optimal care. 20% of colon cancer patients. This has been shown in a number of illnesses, but we're focusing on oncology here. Again, one reference for less than optimal therapy. Mary Jo Lund, who I have the pleasure of working with, showed that 7.5% of black women, 1.5% of whites living in metropolitan Atlanta with a screen-detected localized breast cancer got no surgery. Halstead told us that removal of the tumor was important in 1903, and here it is in 2000. And women are still not getting the results of that research. Insurance matters. This is data that we generated looking at colon cancer. These are 5-year survivals in a Kaplan-Meier plot. Red is stage 1, blue stage 2, green stage 3, yellow stage 4. The dotted lines are uninsured, the solid lines are insured. I just wanted to show you at every stage, the uninsured do worse than the insured. Insurance matters. I also want to point out to you that in the United States, stage 2 insured colorectal cancer has a better 5-year survival than stage 1 uninsured colorectal cancer. Insurance matters. Something that was mentioned this morning, I was thrilled that it was, is the fact that while we've got a 20% decline in mortality for cancer over the last 20 years, we have this obesity epidemic that you can see here, where the obesity rate in adults has doubled. The obesity rate in kids age 6 to 11 has gone up by a factor of 5 since 1970. And obesity is a huge problem by race. You can see 50% of all black women in the United States who are adults are now obese. It's not far behind for Hispanic women. The obesity epidemic is causing a tsunami of chronic disease. Diabetes, cardiovascular disease, orthopedic disease, and as we've appreciated in the last 20 years, cancer. Obesity is related to a number of cancers. Now, you've actually seen an estimate for 2012. The estimate for 2010 is $2.6 trillion on health care. That $2.6 trillion spent on health care compares to about $1.1 trillion spent on food, 18% of our gross domestic product. Keep in mind that obesity epidemic is pushing up all of our health care costs. And as you've seen, when you compare us to other countries, and I just chose Canada, Switzerland, and the United States here, we don't do better by a number of different measures, be it infant mortality, white male life expectancy, per capita costs, we're twice as much as Canada, proportion of the gross domestic product. We don't do well. We don't get what we pay for, even though, as you've seen today, we are the most expensive healthcare system in the world. I would continue, we're a system where some people consume too much healthcare, some people consume too little, and we could decrease the waste and improve overall health if we simply got scientific. Some of the problems in screening is that doctors and the public don't understand screening. There's the perception that all cancer is bad, all cancer must be found, and all cancer must be aggressively treated. There's the belief among doctors that there's no such thing as overdiagnosis. Most actually think that an increase in 5-year survival statistics are evidence that screening is beneficial. Survival statistics are often quoted in advertisements for health centers. People confuse relative risk with absolute risk. Doctors and hospitals tend not to conform to screening and treatment guidelines. Indeed, these guidelines are often flawed, and the IOM is to be congratulated for pointing out some of these flaws. There are huge emotional and financial conflicts of interest on many of the people who create these guidelines. Now, I believe that health care is an issue that needs to be approached ethically, logically, and rationally. We need to appreciate science and the scientific method. As Father Polakowski told me in high school when I was 14 years old, we need to know what it is we know, what it is we do not know, and what it is we believe. And I think he would say today that doctors have a tendency to confuse what they believe with what they know. You see, we have a long history in the United States, and interestingly, not nearly as much in Europe as in the United States, of overusing things. And then years later, sometimes 20 years later, figuring out that we did too many hysterectomies, C-sections, carotid endarterectomies, cabbages, tonsillectomies. We tend to use things before we assess them to see if they actually work. Postmenopausal hormone replacement therapy for 50 years. And Bernadine Healy bled to get that trial together and get it started to show that we were actually manufacturing breast cancer with hormone replacement. We have not come to terms as a group of physicians and scientists with the fact that we manufactured breast cancer by using hormone replacement. The other things, lidocaine after an MI, commonly done when I was a resident. Just 10 years ago, we figured out it causes more arrhythmias than it prevents, and it's net harmful. Hypervitaminosis, Vioxx, erythropoietin to stimulate red cell production, which I'm now famous for referring to as miracle grow for cancer. We used it for 20 years before we figured out it stimulates tumor growth. Interventions introduced without assessment. In some instances, people tried to prevent assessment of them, such as prostate cancer screening. Some people are very proud of the fact that they actually interfered with the PLCO, the US NCI study, to figure out if prostate cancer screening saves lives. Ovarian cancer screening is still advocated by some, despite the fact we have a prospective randomized trial to show that it doesn't work. Bone marrow transplant for breast cancer is, of course, a famous example. There were 220 sites in the United States offering bone marrow transplant for breast cancer, and they all closed down within 4 months of the publication of those studies in 1999 that said that bone marrow transplant for breast cancer was net harmful. We're never held accountable for these things. Imaging. Please note, we have 3 times more CT scanners in the United States than in Canada on a per population basis. We have 5 times more MRI scanners. We don't live longer than the Canadians. It might be appropriate to say we take better pictures of people dying, but we don't live longer than the Canadians. We unnecessarily use expensive drugs. Nexium, rofecoxib, is one of the 10 most prescribed drugs in the United States. It is FDA approved because it has found to be equivalent to generic omeprazole. It is one of the 10 most commonly used drugs in the United States, and it is on the market because it is equivalent to something that costs 1/18 what it costs. By the way, if you know the chemistry of omeprazole and Nexium, you know that they're the same thing. Screening, overuse and irrational use of screening for a number of different diseases. I name names. St. Joseph's Hospital in Atlanta. They offer low-dose spiral CT of the lung for those at risk for lung cancer for $325 cash. They note insurance won't pay for it. They encourage at-risk people to get screened. According to their website, a 40-year-old woman who has lived in an urban area for 10 years is at risk for lung cancer and should be screened. It's on their website today. You might want to Google it. Their business plan relies on insurance to pay for the follow-up of those 25% or more of those non-smoking women in their 40s with abnormal screens. There's a subtle form of corruption in medicine when this is allowed to happen. Prostate cancer. These are the 4 organizations that recommend against routine prostate cancer screening. These are the 5 organizations that recommend for informed decision-making in prostate cancer. This is a van sponsored by a prostate cancer advocacy organization with money provided to them by Kimberly-Clark. Kimberly-Clark is the largest maker of diapers, adult diapers in the United States, folks. Okay, they go around, their business plan is they go to doctors' offices, they go to hospitals, and they go around the country in the winter, and they go to supermarket parking lots. Every January you can hear on the radio that the prostate cancer screening van will be at the Kroger on the corner of La Vista and Druid Hills, and they'll be screening from 9 to 5. They're hooked up with a local radiation therapy group in Atlanta, and Kroger, of course, and WSB Radio, a Cox affiliate. And they offer free screening. Now, they don't do any informed decision-making except to inform people that screening can save your life. And they don't tell you what a marketing guy explained to me in 1998, which is if you screen 1,000 people, it's predictable how many people will have an abnormal screen, how many people will have prostate cancer. It's predictable how many people you're going to sell artificial sphincters to, because you know how many people are going to be incontinent. It's predictable how many penile prostheses you're going to sell, because you know how many people are going to be impotent. However, in 1998, the guy admitted to me, there's never been a study to show prostate cancer screening saves lives, so he couldn't give you an estimate on how many lives would be saved. PSA screening rates, by the way, by race. Again, the poor folks don't do as well as the non-poor folks. More educated folks are more likely to get screened. That's 50% of people with a college education. I asked this question a little earlier. I should point out, I don't have a test. I don't have a pill that you can take. But if you take Fritz Schroeder's European screening trial for PSA, these are the numbers for a guy in his 50s who chooses to get screened once a year with PSA. Now, there are 3 or 4 people in the audience who were going to take my pill, but I won't ask how many men in the audience have been screened for prostate cancer within the last 2 years. But this is the truth. This is informed decision-making about prostate cancer, which don't happen. $2.6 trillion, folks. Overconsumption of health care, ignoring known science, ignoring the scientific method, the greedy feeding the gluttonous, and we're tolerating a subtle form of corruption in medicine where everybody goes to the trough. As Upton Sinclair once said, it's difficult to get a man to understand something when his salary depends on his not understanding it. And as Dr. Hal Sachs said, a professional is someone who puts the interest of his, and I think he would now say his or her patients, above the interest of their own. Getting back to Father Polakowski, the good physician is curious, realizes what he or she knows, what he or she doesn't know, and what he or she believes, and doesn't confuse the three, and asks questions and continues to ask questions. We need to focus on evidence-based medicine. We need to focus on rational use of health care, and we need to denounce the politicians who scare people with the word rationing of health care. Rational use, not rationing of health care, is what we need to focus on. You see, rational use of health care is necessary for the future of our economy. It's actually a national security issue. Quite honestly, we will get health care reform. We cannot afford 25% of our gross domestic product, a quarter out of every dollar, being spent on health care. And quite honestly, that's going to happen within the next 15 to 20 years, faster probably because of this obesity thing. You know, our economy will collapse and health care will be reformed because everybody is slurping at the trough. An essential part of health care is to focus on prevention, rational use of screening, rational counseling for tobacco cessation, rational counseling for exercise, and rational counseling for weight control, and rational counseling for diet. And it is actually possible to decrease costs, improve outcomes, and reduce disparities by using science to guide us. The problem is, we in the United States have not been appreciative of science, and we in the United States really need to start appreciating the scientific method and practicing accordingly. Thank you very much.
So our next speaker is going to tell us all about overuse and underuse of colorectal cancer screening. Is Dr. Goodwin from University of Texas Medical Branch at Galveston.
We just bought the hospital. We're going to shut it.
Thanks. So Harvey started out this morning talking about how cancer touches everyone, every family. And while he was talking, my cell phone went off. And I went up afterwards and got the message. And one of my older brothers had died of leukemia early this morning. And in many ways, he died peacefully in his sleep. In many ways, he was a poster child for excess costs in the last 6 months of life. I'm a primary care geriatrician, and I really only take care of people in their 80s and 90s. I say I take care of people over 75, but I really don't like them much. I like people in their 80s and 90s. And really, an awful lot of my effort with these people in their 80s and 90s is protecting them from overtreatment and from overdiagnosis and from fee-for-service medicine. But I wasn't successful with my brother because even though I'm a primary care geriatrician with some expertise in cancer, I'm also the youngest of 5 children and have never carried any weight in my family in terms of my advice. So I have really two simple messages, and it's going to be more data than you've seen previously. It's just the fact that we can, when we're looking at things like underuse and overuse, we can get pretty good data at the provider level on who's underusing and who's overusing. And as long as we're in a fee-for-service system, which is going to be driving this, we might as well do that and put in plans to control it through measurement. And there is considerable variation among providers over time. So this is the, I'm going to be talking mostly about colonoscopy. This is the risk of colon cancer over a lifetime. And notice it goes out to 95, talking about advocacy for cancer. That's so we can have a 6% risk as opposed to a 4% risk, which would be a normal lifespan. That's how we have a 1 in 8 risk of getting breast cancer, because we're assuming all women will live to silly ages. So in actuality, it's about a 4% lifetime risk, which means that, of course, 96% of us will never benefit from a screening colonoscopy. Now, that's still a highly worth it type of procedure, but it is important to keep that somewhere in our minds. And it also should be important, which we're talking about people meeting guidelines or not meeting guidelines for colonoscopy, that the evidence base for how often we should do colonoscopy is not super good. And so that sort of leaves room for lots of arguments. This is, I think, the best study from the pre-colonoscopy era, where using a barium contrast, a double contrast, a barium enema in the Mayo Clinic in the 60s and 70s, a bunch of people with large polyps, the type of polyps that get gastroenterologists excited, greater than a centimeter, were identified, about 226, and this is just sort of their cumulative diagnosis rate over time. And so even these people with these large polyps had about an 8% diagnosis rate at 10 years and a 3% at 5 years. And that's not the greatest evidence, because we don't know when, this is diagnosis rate, we don't know when they develop cancer and stuff like that, but we are at a level of less than perfect information. So I want to talk just briefly about some studies we're doing. We've been using Medicare for many years to sort of look at provider level stuff, and recently we've been using 100% Medicare with Texas to look at provider level, because Texas, speaking of poster child, tends to be a poster child in terms of overtreatment of just about everything. So in this study, we looked at people in 2009. We assigned them to primary care physicians if we could, and we saw if they were up to date in terms of colorectal cancer screening, either by FOBT or colonoscopy or sigmoidoscopy. And then in this particular study, we were interested in disparities because, as you all know, and as Otis talked about, there are black, white, and Hispanic, non-Hispanic differences in screening. And I'm not going to show you the data because it would take too long to go through, but let me just say that if we just look at people who had a primary care physician, to whom we could assign a primary care physician in the Medicare data, that took care of 90% of the black-white disparity. Very similar to the socioeconomic issues you were talking about. People with primary care physicians had very little disparity. It was not as true for Hispanics, but it was true. And then the rest of the disparity was taken care of by the quality of the primary care physician. The other point is, it was possible to, we have enough events here, we have enough people in the denominator that we can assess primary care physicians in terms of their performance and on their patients getting colorectal cancer screening. Those rates are stable. In multi-level analyses, we can show that about 20% of people of PCPs have rates that are significantly higher, and about 18% are significantly lower than the mean, and those are stable from one time period to the next. So it's possible to look at that information. I want to go on to overuse of screening colonoscopy, and I just want to go briefly through a couple of studies. As you know, and I think as Otis mentioned, there's been a lot of expert panels recommending screening colonoscopy. Well, I guess you were talking about mammography, but screening colonoscopy, and then recommending a frequency of screening colonoscopy. And there is not an expert panel that thinks that you should get screening colonoscopy more than every 10 years if you've had a normal or negative screening colonoscopy. And this is kind of a bedside to bench thing for me, because I was having these 82-year-olds come in and say, well, I've been called back for my normal screening colonoscopy, and they'd gotten one 3 years earlier. Or I had a 92-year-old getting called back for a screening colonoscopy. So we had the data, so I said, let's study it. So this is a complex slide, but this is the type of thing you have to do when you work with Medicare data, which is get as clean a sample as possible. So we got everyone. This is a national cohort, not the Texas cohort. This is a 5% national, where we took everyone who early in the 21st century, 2001, 2003, had a colonoscopy. And then we took the ones for the next step where they didn't find anything. In other words, they didn't bill for any biopsy or fulguration or stare, so they had a negative colonoscopy. But then we said, well, yeah, but we just want to look at people who had a negative screening. So we threw out anyone who had any diagnosis on their bill or in the 3 months prior to their bill that was something like anemia or GI bleeding or even change in bowel habits. So we wanted a real clean. The problem with trying to assess screening colonoscopy is it wasn't reimbursed by Medicare all during the 90s when everyone believed in it. So gastroenterologists evolved to using creative diagnoses so that they could get reimbursed for something they believed in. And because of that, they don't bill for screening colonoscopy. So when we did that, we then were left with a sample that had a negative screening colonoscopy in 2001, 2003, and we could just look at them and see sort of when they got their next colonoscopy. And the bottom line is the one that is the people who had the negative screening colonoscopy in 2001, 2003. And you can see that by 7 years, almost more than 40% of them had a repeat colonoscopy. And you can see these little bumps around 36 months and around 60 months as if they're on schedule, okay? When we then looked at those repeat colonoscopies to whether they were screening or whether they had some indication, and we were very generous in terms of applying indication, we found that about 23%, if we gave our most generous algorithm for it might be indicated, about 23% of people with a negative screening colonoscopy had a repeat screening colonoscopy within 7 years. And this is the geographic distribution of this. That's Lubbock down there in Texas. That's not one guy in Lubbock, but that's Lubbock. And you can see this the same type of geographic distribution that you can see so often by the Dartmouth group and others when looking at overuse of medical care. And then the final study is, can we look at the individual colonoscopist? So for this, we had to go back to 100% Texas data, where we, when you look at Medicare, even fee-for-service Medicare, you're getting 40% of the total volume of some of these, most of these providers. And so you can really do good provider level analyses. And so we looked at people over age 70 who received a colonoscopy over a 12-month period in 08 and 09. We looked at the people to be potentially inappropriate. Once again, we were using very, very, what I would consider generous, either in the prior 3 months, if they had any diagnosis that suggested they might need a colonoscopy, or on the claim. Then we said, yes, this was probably indicated. And then we looked at the percent of potentially inappropriate colonoscopies as a percent of all colonoscopies for each provider. And so in the younger old, the only possibly and probably inappropriate were those that were early repeats. And it was only about 7 to 10% of the people, 70 to 75, or I'm sorry, 7 to 10% of the colonoscopies in the 70, 75% that were judged to be potentially inappropriate. In the 76 to 85, using United States Preventive Services Task Force criteria, taking out the high-risk people, it was higher. It was about a third. And then it fell, which is nice, in people over 85. A higher proportion of the people over 85 who received colonoscopies did for stated reasons, not screening. But when we looked at the factors associated with risk of inappropriate colonoscopy at the individual level, some of them are what you would expect. Males are at higher risk. Interestingly, high comorbidity had a desired effect in that people who were old and had comorbid illness were less likely to get screening colonoscopy. High education was associated with less likelihood, which surprised me, because typically that tends to lead to over medical care. Oh, and I guess in terms of provider factors, provider volume was a very big, those in the top quartile, these are quartiles of annual Medicare volume. Those in the top quartile were about 70%, or those seeing someone in the top quartile were about 70% more likely to get an inappropriate colonoscopy. If they were seen in an office setting or an ambulatory surgical center setting as opposed to a hospital-based clinic, then they were more likely to get an inappropriate. And also there is some differences between specialists. I'm not quite as sure of this because I think it's true for the generalists. I'm not sure that there may be some confounding with surgeons where they may be seeing some survivors that we didn't pick up with our data. There is variability at the level of the colonoscopy provider, and this is just from a multi-level model where you can show that, you know, there are people significantly higher, around 10%, and around 10 or 15% who are significantly lower than the mean at the colonoscopy level. And once again, these are very stable over, if we went back and did 2 years earlier, and there was a high correlation between the high people in 2009 and the high people in 2007. And then when you look at these people, they're more male. These are now, we're looking at the providers. So you can begin to characterize the providers. They're more likely to be surgeons. That's the one finding that I would be a little careful with because I think there still may be a little confounding in this analysis. They're older. None of the high colonoscopy users were recent graduates. They're more likely to be U.S. graduates, not international medical graduates. And very much more likely in Texas. And they're high volume. And so in other words, these are well-established colonoscopists who have high volume businesses who are good old Americans. And this is the final slide showing that there is variation within Texas. This is also stable from year to year. So you can look at areas that have very high rates of inappropriate colonoscopy. You can do this. More recently, we've done these same types of analyses except using life expectancy, estimated life expectancy based on age and comorbidity, and basically find the same patterns. Lubbock actually doesn't show up as much as that up there towards the middle is Sweetwater. Texas has very pretty looking towns, and when I was running away from Hurricane Ike a few years ago, I spent a couple days in Sweetwater without getting colonoscoped. Though I may have been one of the few. Thank you very much.
Our third speaker is Dr. Denise Aberle. from UCLA, and she's going to talk about lung cancer screening and some of the preliminary cost effectiveness study. All the slides are available online, just so that you know, okay?
So it's a real pleasure to be invited to speak here, and I want to thank both Patty and Tina for that. Okay, so now I just need to figure out which way these go. So I am going to be talking about low-dose helical CT screening, and you all need to listen up because I think it's unlikely we're going to have another randomized controlled trial that will actually show this, the data that we found. Bill Black, who is the architect of the cost effectiveness analysis from Dartmouth, was unable to be here, so I'm going to try to fit in a little bit of what he would have presented had he come. Most of you are familiar with the NLST. It was an NCI-sponsored randomized controlled trial that was powered to detect a 20% difference in lung cancer-specific mortality. We ultimately accrued slightly over 53,000 individuals who were between the ages of 55 and 74 and who had a current or former heavy pack year smoking history. These folks were randomized to receive either chest x-ray or low-dose, low-radiation dose helical CT scans annually for 3 screens. We followed them for about 6.5 years median and were able to ascertain the vital status in over 95% in both arms. These show the screening results by screening round, and if you look at this, I have circled the total average, but it holds true at each of the screening time points, and that is that there was a 3-fold higher increase in screen positivity in the CT arm. Moreover, among any individual who underwent all 3 of the low-dose helical screens, about 39% of them had at least 1 positive screen. This shows the lung cancers that were diagnosed in the NLST based on their screening trial result and the time period. And I think you can appreciate that the most common lung cancer or the highest percentage of lung cancers diagnosed in the CT arm were screen-based, meaning that they occurred in face of a positive screen. That was not the case in the chest x-ray arm, where the majority of the patients were actually diagnosed in a no screening period, and by that, about 90% of the time that was in the post-screening surveillance period. Lung cancers were also observed in screen-negative patients, although this was more common in the chest x-ray arm, and these are the interval cancer rates, such that overall, not surprisingly, with the more sensitive test, we were able to see more lung cancers with CT than with chest x-ray. This is a kind of complicated slide of the stage distribution of these lung cancers. These are absolute numbers of lung cancers, and along the x-axis is stage. Stage 1A, the most eminently curable, intermediate stage, and then advanced stage 3 and 4. And I think you can appreciate, oh, by the way, on the bar graphs, the differences in color represent whether these were screen-detected interval cancers seen in screen-negative patients or in the absence of screening. And I think the important take-home messages here are that in the CT arm, early-stage lung cancers were more than 2-fold greater than in the chest x-ray arm. Most of the screen-detected cancers, roughly 80%, or most of the early-stage lung cancers in the CT arm were identified with screening, whereas that was not the case in the chest x-ray arm. Only about half or slightly under half of early-stage lung cancers were detected with chest x-ray screening. The other not surprising point to be made, and that is that if we look at these interval cancers occurring in patients who had negative screens, we can see that by and large these were advanced stage lung cancers. Not surprising, we would expect biologically indolent cancers to be observed in the setting of an ostensibly negative screen. This was true for both arms. And then finally, very importantly, we did observe an absolute decrease in the numbers of advanced stage lung cancers, such that low-dose helical CT did result in a stage shift to earlier stage lung cancers, which largely accounts for why we observed a mortality benefit. When we looked at the complications of patients who underwent screening, recognizing that our positive predictive value on the CT side was less than 4%. So the vast majority of positive screens were in patients without a diagnosis of lung cancer. We divided the complications into major complications, intermediate complications, and minor complications. And I'm showing you only the data for the major complications, which were usually cardiac or respiratory arrest, myocardial infarction, pulmonary embolism. It also included surgical complications like bronchopulmonary fistula or empyema. And you can see that if we stratify these patients by whether they had a cancer-associated positive screen or no cancer, that the complication rates were acceptable in the patients who had screen-detected lung cancers. In fact, our mortality rate, even 60 days out from an invasive procedure, is probably lower than the national norm. And this may partially be because most of these academic centers' surgeons were dedicated thoracic oncologic surgeons and not general surgeons. The other point to be made is that in those 17,000 some individuals who had a false positive screen, the complication rates were very low. These are the causes of death. The most common causes of death were lung cancer, other cancer, cardiovascular disease, or respiratory disease. And if we normalize the lung cancers per 100,000 person years, we in fact did achieve a 20% relative mortality reduction and an absolute mortality reduction of 4 per 1,000. Somewhat interestingly, we also observed a modest but significant decrease in all-cause mortality. And this tells us a couple of things. The first thing is that I have already alluded to the complications occurring even with high false positivity rates did not in and of itself provoke premature mortality. But the second important aspect of this is that these patients weren't spared a lung cancer death only to die of some other comorbid illness. And that's an important feature, in fact, one that has not been shown before in a screening trial. So we saw more lung cancers, we saw a true stage shift, we saw a 20% relative decrease in lung cancer-specific mortality, few complications, and a modest decrease in all-cause mortality in the low-dose CT arm. So what are the harms of screening? I think the primary harms about which we are most concerned are radiation, the potential for overdiagnosis, and high false positivity rates. So let's look first at radiation. These are data that have been taken from a couple of different authors looking at radiation risks from diagnostic imaging. And if you divide, if you look at the background risk of lung cancer, obviously the highest risk for lung cancer in both males and females is smoking, and they have a several-fold increase in risk relative to the non-smoking population. If we try to determine the excess risk of a low-dose helical CT scan, which was calculated at 5.2 milligray and looking at organ-specific dose, not effective dose, which is total body, but organ-specific, you find that there is a small incremental risk associated with a single low-dose helical CT scan. The greater concern is that although the incremental risk would remain small if you scanned these individuals over a period of 25 years annually, these in fact do have population differences. And in this paper, those population differences would have accounted for just under 2% of all lung cancers. The good news is that the CT doses in the NLST were about 20 to 50%, those that were originally reported by Brenner, and our technology vendors are actually developing additional methods that should help us to reduce lung cancer-specific mortality. But it obviously begs the question of who should be screened, when we should begin screening them, and at what frequency for what duration of time. With respect to overdiagnosis, I have to tell you I'm actually a little less, I feel less comfortable with the notion of overdiagnosis than I did when I first started the trial. I think all of us in practice have seen these patients who have had very tiny little incidental ground glass nodules. Now you can see that this actually does evolve over a period of time, and I hate to tell you, but this patient would probably be managed relatively aggressively with sublobar resection these days. However, this patient was not until she came back with an overtly invasive T1A lung cancer that was N2 positive. So this patient was actually stage 3A at the time that she returned for diagnosis. The problem that I have with overdiagnosis is that we can't distinguish between those lesions that will stay premalignant or pre-invasive and those that will at some point sustain that genetic hit that converts them into an overtly invasive neoplasm. And we have to develop better methods in order to be able to discriminate between these lesions so that we're not scanning everyone who has ground glass nodules. So how do we reduce the false positive rates? There are a couple of easy ways to do this relative to our experience in the NLST. And the first and most obvious is that we just redefine what constitutes a positive screen. Our positive screen threshold was a nodule of at least 4 millimeter diameter. As we increase that threshold, we will reduce a substantial number of itsy bitsy micronodules, which we should probably not be following on a regular basis. The second thing, which is interesting, and that is that we had a dichotomous interpretation approach. You were either positive or negative. I think we are beginning to see that just as in the BI-RAD system, in which there is a gray scale for levels of suspicion for malignancy in a finding on a breast, on a mammogram, we should probably be doing the same thing. And I think that we should be doing this for a couple of reasons, not the least of which is that it more appropriately allocates the level of risk or level of suspicion that we have, communicating that to both patient and primary care provider. I think we also can do a better job of figuring out who should be screened. Our criteria were based only on age and a heavy pack year smoking history. I think that there are at least 3 risk prediction models that have been developed and have been most discussed in the literature. Peter Bach did one, Margaret Spitz did one while she was at MD Anderson, and then more recently the Liverpool Lung Project. We currently have one international trial that is predicating eligibility on a risk prediction model that includes variables of gender, smoking history, asbestos exposure, et cetera. And I think we can do an even better job than the models currently allow us. I'm going to pass on this other than to say that I think we can also do a better job of managing these patients who have indeterminate nodules, and some of this may actually also involve diagnostic modeling. Okay. All right, so now I'm going to move into what Bill would have discussed with you had he been able to be here, and that is kind of his back-of-the-napkin cost-effectiveness analysis. I will tell you that a formal analysis is being undertaken not just with Bill at Dartmouth and some of his colleagues, but also Rand Corporation, and we're desperately hoping that we'll be able to get this in for consideration for publication within the next couple of months. But he did this about 1.5 years ago. In fact, it was first published in the Cancer Letter. And what he did was looked at the ICER, which is what we'll be looking at also for the formal CEA, that being the incremental cost effectiveness ratio, which simply, deceptively simply, represents the differences in costs over the differences in this case, life years between 2 different scenarios. He used $2,008 and compared low-dose CT to a no screening scenario using a societal perspective and a lifetime time horizon discounted to 3%. He made 4 assumptions. Those assumptions were that, first of all, everybody's going to undergo 3 annual screens, as was done in the NLST. Secondly, that, as in the NLST, about 40% of those people would have at least 1 positive screen. Third, that for every positive screen, those individuals would undergo 2 additional CT scans, and then he decided that the treatment costs would just cancel out. So these are the costs per screenee that he came up with relative to 0 cost in the non-screening scenario, We looked at Medicare reimbursement for a non-contrast chest CT, which is about $300. He added indirect costs of time travel of about $100, making the cost for a single CT scan $400. Now factoring in this 40% positivity rate, then adding to the 3 screens the additional costs for workup, that brought the total cost of CT screening to about $1,520. With respect to the risk of lung cancer, he used data that came from the public domain, the NEJM paper that was published on this, as well as some actuarial data. And the risk of lung cancer in the chest X-ray arm was 0.017. We saw a 20% mortality reduction, so therefore the product of these two would be the absolute risk reduction of 0.0034. We also know from Brown et al. That the years of life lost in a patient with lung cancer averages about 12 years, and therefore the product of these two would be 0.041 for years of life gained. So if we do difference in cost over the differences in life years, it came out to about $38,000 per life year. Now, the formal cost effectiveness analysis will obviously vary from this for a number of reasons. Number one, the NLST cohort is actually healthier than the comparable US population. So that may artificially improve the cost effectiveness ratio. Secondly, we'll be basing our data from longer term follow-up. These initial calculations were based on a follow-up of the NLST lung cancer patients through January of 2009. We now have a full data set that takes us through December of 2009, so the differences in survival may influence the cost effectiveness analysis. Finally, Brown's actuarial data did not factor smoking into the years of life lost with lung cancer, which obviously will affect survival. And then finally, we're going to be basing our costs on actual screening compliance as well as utilization as is determined through Medicare abstraction and correlated with the over 65 Medicare group. I'm going to finish by mentioning a couple of things that I think will be challenging if low-dose helical CT screening is implemented as a part of national policy. And most of you are aware that the CMS will be looking at this once they have more data on cost effectiveness, along with the U.S. Services Preventive Task Force. So I tend to look at the challenges of implementation in 3 different boxes. And I think the first box is clearly going to be the screening programs themselves, which should not be run by radiologists, should not be run by thoracic oncologists, should not be run by pulmonologists, but should in fact have everybody's skin in the game, including the primary care physicians. Because these screening programs should not be simply doing a low-dose helical CT scan and interpreting it. I think we need to be doing risk assessment for a couple of reasons. Number one, we need better data on who should be screened and what happens across different risk profiles of individuals. And we can also use individualized risk assessment in order to individualize what should also be a part of this, and that is aggressive smoking cessation programs and durable smoking abstinence. That alone will make low-dose helical CT screening infinitely more cost-effective. Finally, hopefully we can add chemoprevention, although there is really nothing on the horizon just yet. I do believe that the implementation of CT screening will have significant impact on radiology practice. It will largely be up to my discipline to provide the levels of standardization across all kinds of CT platforms for how we acquire these images, the maximum acceptable radiation exposures, how we interpret them in a standardized way, and the kinds of management algorithms we use in the setting of different kinds of positive screens. And this is going to take a little while. If it is decided, as has been pretty much in Europe, that image analysis should be part of the algorithm for CT screening, that will clearly have implications for workflow. There's one other thing, and I've stuck it under the radiologist, but this applies to the screening programs. And I definitely believe that we are in this collaboratively with primary care to follow these patients. I think we have the opportunity, given appropriate information systems, to be able to responsibly follow these patients. Secondly, I think that the primary care arena will have significant challenges with implementation. First, they're going to have to believe this evidence and decide that the benefit outweighs the risk. If they do so, then we're now asking them to incorporate into the already too limited amount of time they spend with individual patients to discuss and educate patients with respect to lung cancer screening risk and benefit. They will ask their staff to be scheduling these patients, and that 25% who have positive screens, if we use NLST algorithms, will in fact then need to be followed up. And I think that's one of the major reasons why the screening programs need to assume mutual responsibility for following these patients. Finally, the individuals at risk themselves. There will be major challenges in educating us so that we don't have the worried well at the age of 40 coming in for their low-dose helical screen, and we make sure that it is applied appropriately to everyone across all socioeconomic strata. We don't want to convert lung cancer screening and lung cancer mortality reduction into a disease only of the economically able. Finally, I think a major problem that we share specifically in the arena of lung cancer screening is stigmatization, and we all have it. The patients have it, the patient's family members have it, and we as physicians have it. In fact, that was a concern voiced by some highly respected individuals at the Board of Scientific meeting when the National Cancer Institute was considering this trial. This is a preventable disease. You kind of deserve what you get. And to this, I would say, get over it. I think probably one of the most provocative and thoughtful approaches to this is an advertising campaign that has been done by the Lung Cancer Alliance. And I had an image in here, but in the interest of time, I took it out. You should go to the Lung Cancer Alliance website. What they've done is to suggest that we make notions about who should be screened or who should die from lung cancer for entirely fallacious reasons, and that 1 in 5 people who develop lung cancer never smoked, 3 in 5 are former smokers, and 1 in 5 haven't been able to quit. Nobody deserves to die of lung cancer. And with that, I will conclude. Oh, there's one other thing. I was asked to comment on how we could prevent the indiscriminate use of CT screening, like the example that Otis showed us. And I don't have any magic bullets. What I do think is that it will require considerable communication within the medical disciplines and within the community at risk. I also have a difficult time, given that this is an ionizing radiation and that there are risks associated with this screening test. We'll find it difficult to believe that this will actually happen and that we will rapidly achieve levels of standardization and quality control without some form of regulation. It took mammography about 40 years of screening before there was initially voluntary and then ultimately legislative regulation. And I'm hoping we can do it faster in lung cancer, but I'm pretty sure we're going to need to do that. And then finally, I'm also, I think one of the ways that we can make lung cancer screening cost effective is through vendor support and the development of the kinds of IT systems for tracking that will be necessary in order to manage these patients. Now I'm done.
So all the speakers, please take your seats. We have about 20 minutes for Q&A. Any? So we have a question over there, I think.
Yeah, I have a brief comment and then a question that I'd like to address to all three of the speakers. My name is Barry Kramer. I'm at the National Cancer Institute, by the way. First, very briefly, I thought all three talks were really superb and addressed some of the core issues that we've been trying to talk about all day, and I really appreciated the talks that you gave. A brief comment to Denny is that the issue of overdiagnosis is, as you know, very complicated, and at the individual level, it's virtually impossible to detect, to know whether it did or didn't occur. I think we would agree that even in the National Lung Screening Trial, there was some evidence of overdiagnosis, as evidenced by persistent excess of lung cancers in the low-dose CT arm compared to chest X-ray arm. You're correct in saying it's very hard to quantitate it. I think it's fair to say that it's not large, but it's there. It may be smaller than the overdiagnosis associated with mammography, and certainly is smaller than the overdiagnosis that is associated with PSA screening for prostate cancer, at least in my opinion. But the question I have is, given that all three of you put emphasis on the issue of education for patients, or the population, as well as for physicians, I wanted to sort of get at that. There's sobering evidence out there, as I think Otis was alluding to, that a large proportion of physicians incorrectly look to survival after the date of diagnosis as the strongest indicator of benefit of a screening test, when it is well known that it's the weakest indicator. And so when we say we would like a smarter healthcare system, more efficient healthcare system, to employ the cognitive skills of physicians, in essence, many physicians are cognitively impaired. And how do you get at that issue of training them to know that they're relying on a very misleading indicator of benefit in this case?
Barry, very perceptive question. As usual, I don't have a simple answer. The problem with physicians not understanding screening, I actually do think is getting better. And it arises over the fact that over the last 30 years or so, we have more and more people who are MD, MPHs. We have a growth of a number of schools of public health. And in usually the second year of the curriculum in medical schools, doctors are actually learning about screening and epidemiology now. And so, you know, I still see patients, and I still supervise residents and fellows, and I find them actually challenging me on my overuse of medicine, and is this legitimate? And I actually am thrilled when that happens, by the way. So I have some hope for the future of medicine, and I could even, over a glass of wine, tell you I think it's because medicine's become so expensive. Medical school has become so expensive. People don't go to medical school because they're interested in making money anymore. They go to medical school because they're interested in taking care of patients.
I don't know if,
So I have some good news and bad news. The good news, we were funded by the state of Texas to sort of look at cancer care in Texas. And one way we've been doing that is in the dissemination aspects, is just writing op-ed pieces for Sweetwater Times and Houston Chronicle and Dallas Morning News. So big and small papers. And we have our press, you know, send them out. So one article might, one op-ed piece may get published in like about 16 different newspapers around Texas. And I've been sort of focusing a lot on PSA over the past year in terms of putting out columns. And it's amazing how it's changed. I still get these incredibly angry, I just did one on you know, how anyone who was a survivor of prostate cancer would feel, you know, sort of taking people through, you know, the steps of being diagnosed and being treated and knowing that your life was saved from this test, and what an amazing leap it would have to, you know, you'd have to go through to have to question that. But the responses, while they're still angry, have changed. So that last week when I published one, all the letters were, well, of course no one would recommend routine screening for prostate cancer, but, you know, as opposed, so it is, no one ever says they were wrong, of course, that's not our way, but it seems to be changing somewhat slowly and at the patient level, and I think I agree with Otis at the provider level. The bad news is we just looked at United Healthcare data from 2001 to 2011 through to December 2011 and PSA screening for men 40 to 64, and there was no change with the publication of the trials, or we only had 2 months of data after the Preventive Services Task Force recommendation and the ACS changing, but there was no blip at all. There was, I mean, it's been published in men over 75 when the Preventive Services Task Force withdrew its recommendation, there was about a 3% absolute decrease, but we couldn't find any nationally.
Barry, I think I'm probably not adding anything that my colleagues haven't, but I agree with Otis. I think it starts in medical school, and we are beginning to see that as a fundamental component of medical education. I think for those of us that are already out in practice, for whom survival is a confusing notion, if you haven't been introduced to it, I think we have to use the medical literature. And then finally, if the medical literature doesn't work, you do exactly what you did in Stillwater, and that is put it out to the public, because I think that will most certainly encourage physicians to become more familiar with it.
Larissa Neklada of Harvard Medical School, Harvard Vanguard Medical Associates. So I continue to applaud the new position by the ACS to embrace evidence-based medicine, and I think that partly some of the issues that Dr. Brawley, that you pointed out, was as a result of ACS's sort of traditional positioning on cancer screening at all costs. So I continue to applaud that change in the ACS and its positions. Regarding the lung cancer screening, as a primary care provider, I really worry about it. I worry about it because, as you mentioned, once the practice disseminates into community-based medical centers and practices, I think that the quality will probably not be at the quality that it was in the academic medical centers. I think the false positive rates will go up. I think the additional follow-up and procedures will likely go up. And I also worry about the allocation of resources, both financial resources and also provider time. I think that in discussing the pros and cons of lung cancer screening, we should really be discussing smoking cessation. And I think that primary care providers often say that they're not reimbursed enough, they don't have the time to discuss it. But I think here we have this, in a way, a golden opportunity to use the resources appropriately and then possibly reduce lung cancer and a whole host of other medical conditions.
And I can only say that I share all of your concerns. I think it is a legitimate concern that we need desperately and very rapidly, if we're going to implement this, to achieve standardization and some form of oversight.
And may I just say thank you for your statements about the ACS and its evolution. I think one of the great problems in medicine is that medicine has oftentimes not evolved over time. You know, there was a time when the Halsted mastectomy actually was very appropriate. Unfortunately, that was probably from 1900 to about 1935. And it took us another 40 years to realize that it was, you know, it had evolved, medicine had evolved to the point that the Halsted mastectomy was inappropriate. And, you know, quite honestly, it was another 15 to 20 years to convince everybody in medicine. The problem with overdiagnosis and survival and treatment, I've actually gotten some traction in trying to explain it the following way. In the 1850s, a group of German pathologists did a series of autopsies using this new thing called the light microscope and these new series of German chemicals, which we now call H&E staining. And they did these autopsies, and Virchow was one of them. He was a marvelous artist, and he would do an autopsy and he would draw what he saw under the microscope, and that actually became our definition. This is breast cancer, this is lung cancer, this is prostate cancer, so forth. And they went into the various subpathologies and so forth. Now, medicine's failure to evolve is really the following. Somewhere in a hospital near us today, using mammography equipment that was invented after I was born, using ultrasound equipment that was invented after I graduated from high school, and using needle biopsy equipment that actually was developed after I became board certified in oncology. Somebody's going to find an 8-millimeter tumor in a woman's breast, and with this new biopsy equipment be able to get a piece of it and send it to a pathologist who's going to use the same H&E stain that Virchow used a 2012 version of Virchow's light microscope. And that pathologist is not going to say this is breast cancer. That pathologist is going to say this is what Virchow said killed that woman in 1850. And I would propose to you that the great problem we have in pathology is the equivalent, the pathologic equivalent of racial profiling. You see, that 8-millimeter tumor may very well not be programmed to grow, spread, metastasize, and kill that woman, but by God, we can cure it, and we don't need to cure it. And prostate cancer, we already know that it's between 40 and 60% of all the localized prostate cancers we find fulfill that criterion of it looks like something that kills somebody Virchow autopsied in 1850, but we know it's not genomically or genetically programmed to grow, spread, metastasize. But we can cure it, and hopefully we won't kill the guy in the process of curing it.
Okay, so I have a question for all speakers, and I don't want to sound like a cold-blooded economist, but I've been thinking about this issue that if we have limited resources and we can invest money to find a cure for cancer, so one day if there is a cure for cancer, there is that magic pill, you just take it and then the cancer will go away. In that case, can we at least afford to screen less, like, reduce the frequency of screening, or be very, very selective on the screening population? So my question is, what do you see is the interaction between treatment advances and the cost effectiveness of screening?
Can I just say that we have one of the problems in terms of communicating with patients or with other physicians is that the economists were in charge of the analyses and kind of the narrative about over treatment for a long time. And as has been said famously by many people, something can't be cost effective if it's not effective. And the problem with the economic is, of course, it just leads immediately to rationing, to I wouldn't even call it paranoia because it is so widespread. It's a natural feeling. And of course, that's not the issue. The issue is improper treatment, harming people, giving them a diagnosis they wouldn't have, giving a lot of women in their 40s a diagnosis of breast cancer they might not have, giving a lot of men a diagnosis of prostate cancer they wouldn't have, giving people a diagnosis of heart disease they may not have with various screens. So we can go so far in terms of stopping inappropriate treatments without ever thinking about cost effectiveness. Do you understand what I mean? We can put all our energies there, and the reason it would be important is if we never mention a dollar again, then at least, until we get that under control, then we will have far less resistance by physicians and by the general public, which still hears the dollars in the back of their head, even though that's not the message anymore.
Well, being a University of Chicago graduate, talking to a University of Chicago professor, let me tell you, I think one of the problems is that free market economics has become totally screwed up in medicine, and the question is how to fix it. I'm not smart enough to know exactly how to fix it. Almost everything else that I can think of, be it computers and what have you, over time becomes less expensive. It's only in medicine where things become more expensive. I don't know if we need to have a situation where more people have skin in the game, where people can have to actually pay for some of these very expensive healthcare interventions that they demand and don't need. I don't know how we take care of people who can't afford it but do deserve it in terms of medical interventions. I'm not smart enough to have an answer for you.
Any other questions from non-economists? Okay, so yeah, Brenda? Yeah.
Brenda Nevajon, Duke University School of Nursing. It's not so much a specific question, but sort of a gestalt from the consumer point of view, who reads newspaper articles and sees that 15-second on the nightly news about PSA, non-PSA, mammo, non-mammo, because of what comes out of our field. And I think, Otis, it does go to some of what you were saying. And so they go to their provider and say, I want that mammo. I don't care what the news story said because my best friend down the street had a mammo or had a PSA or whatever. And so the provider's on the front line of dealing with a patient, a consumer, or however you want to call somebody in their practice who says, I want. And I think that's something in our educational process also we don't do really well. How to reframe that, basically to get to the point of saying this really isn't in your best interest. And I don't know whether education's even starting to think about taking that on. So any comments?
I can tell you as a primary care provider, I just make rules for myself. And one of the rules is if a woman demands a mammogram, I'm going to get the damn mammogram, no matter how old. Because, I mean, you have to understand, and you obviously do, but it's all the dynamic goes in favor of screening. All the dynamic. No one ever says, oh, thank God, my life was saved for not getting a PSA, or, and so, in a way, I mean, I hate to say this, and it's a despicable thing to say, but a couple of high publicity lawsuits, would do it. I mean, just in some state, probably Texas, where the trial lawyers rule, but where someone, sues for $40 million because they were overdiagnosed, that would begin to get attention, not just of the physicians, but of the American public about this concept.
Yeah, I keep thinking about one call. I get these calls about people who want to sue for PSA screening and what have you, and usually to defend the doctor who didn't do it. But I got one call. This lawyer was representing a man who got screened at a free event at a mall. And he had a slightly elevated PSA and was referred to a urologist. The urologist looked at the guy in his wheelchair with his oxygen tank, his history of triple bypass surgery, and said, sir, you're 80 years old. Why don't we try to forget you ever had this PSA? And this fellow actually tried to sue the people who offered him the free PSA. Maybe I should have signed on as an expert witness there, but I usually choose not to do those sorts of things. One of the things that I've heard doctors say is, if somebody asks me to prescribe this antibiotic or this screening test or this procedure, that procedure, if I don't do it, they'll take their money and they'll take their insurance and they'll go down the hall in the same building to a doctor who will. And so there is actually a lot of patients demanding things that they see on advertisements, and women, men and women, getting them. In my book, I actually talked about a woman who insisted on getting adjuvant chemotherapy for her Dukes A stage 1 colon cancer, when the studies on stage 2 colon cancer show that it doesn't work. And she got the chemotherapy, and for getting the chemotherapy, she ends up with numbness and tingling in her hands and feet and some hair loss immediately. And of course, she now has an increased risk of getting myelogenous leukemia because of the chemotherapy. I don't know if it helped prevent her colon cancer or not, but people do demand it. Doctors do give it because they're afraid they'll lose their business.
Denise, any comments? Because I'm sure with the lung cancer trial, this is going to happen with patients demanding.
Yeah, I think, you know, this is on a very small scale, but the concern about self-referral of individuals, I think one of the ways that prudently we will probably try to handle this is to actually have the patient sign a consent form stating that we have advised them against screening because of their risk profile, and they have elected to go ahead, and have them sign a statement.
Okay, so I think we have time for one more question.
I'm Margot Fromer. I'm a reporter from ASCO Post. All day and at previous meetings about paying for cancer care and other types of health care, I have no doubt that the people who in this room could sit down for a week or 2 or 3 and work up a plan of how to make cancer care more affordable and more available to Americans. I have no doubt that they could do it, because I think that the problems are obvious, and I think that if you think about it for a little while, you could come up with solutions. However, what would happen if this could happen? What would happen when it was presented to the American public, including cancer care providers who are also members of the public? And anybody who wants to comment on that, I'd be interested.
I think what you're saying is people know what they want and they want it. And unfortunately, that's true. You know, I've actually sometimes said that I feel a little bit like that Marine colonel in that Tom Cruise movie, An Officer and a Gentleman, when I want to scream, "You can't handle the truth," which is, I think, the case with the American people. I actually do believe that our economy is going to have to crash before this problem is solved.
I don't.
Okay, that's time to take a break.